Hey, all you cool cats and kittens. Thanks for tuning in to my presentation on an examination of clinical trials to improve wound repair in patients. My name is Jose Luis Reyes. So, student learning outcomes. Upon completion of this presentation, you, the student, should be able to identify the four phases of wound healing, describe the function of key biological components in wound repair, identify factors that affect wound healing, and assess the effectiveness of clinical treatment plans for wound repair. So here are some keywords and concepts to help us identify the four phases of wound healing. The first phase is hemostasis, the process that when the wound is being closed by clotting, and it includes macro and micro interventions, and we'll go over that later on. Inflammation, the second phase, which is the process of localized swelling by increasing flow of transudant. The third phase is proliferation, the process in which the wound is rebuilt with new tissue made up of collagen and extracellular matrix. And the final stage is remodeling, the process in which collagen is converted from type 3 to type 1 and fully closes. And now some keywords and concepts to help us understand the key biological components in wound repair. First, we have the platelets, which are responsible for the formation of the thrombus, activation of the coagulation cascade, and release of inflammatory mediators. We also have neutrophils, which are responsible for the phagocytosis of bacteria, wound debridement, release enzymes, and they increase vascular permeability. We have the keratinocytes, which release inflammatory mediators, stimulate neighboring keratocytes to do the same, and are responsible for neovascularization, which is the formation of new blood vessels. We have lymphocytes, which regulate proliferation and collagen deposition. And lastly, we have the fibroblasts, which synthesize the granulation tissue, collagen synthesis, extracellular matrix, and the release of inflammatory mediators. And here on this slide, we can see that the keratocytes, the fibroblasts, and the collagen fibers are all coexisting together, but it is once they are activated because of the wound that they will go into effect and start doing all of these things that I had just mentioned. So let's go back to that first phase, the hemostasis phase, which is the first step of hemostasis is when the blood vessels constrict to restrict blood flow. And now this is that macro intervention that I had mentioned. And some blood vessels are up to 5 millimeters are able to do this and constrict all the way to cut off blood flow. But anything bigger than that is going to require these micro interventions, which involve the platelets sticking together in order to seal the break in the wall of the blood vessel. Finally, coagulation occurs and reinforces the platelet plug with threads of fibrin, which are like a molecular binding agent. The platelets adhere to the subendothelial surface within seconds of the rupture of blood vessels epithelial wall. After that, the first fibrin strand begins to adhere. As the fibrin mesh begins, the blood is transformed from liquid to gel through procoagulants and the release of prothrombin. The formation of the thrombus or clot keeps the platelets and blood cells trapped in the wounded area. As you can see on the image on the left, the platelets are starting to collect, and then more up closely, we can see on the right that the fibrin threads are starting to form, and they're catching the erythrocytes and the platelets. And slowly, as more of them start to clump together, in the final phase, we'll see this thick, interconnected web of fibrin threads creating this plug. Next, the inflammation phase, which begins right after the injury when the injured blood vessels leaks translucents made of water, salt, and protein, causing localized swelling. Inflammation both controls bleeding and prevents infection. The fluid engorgement allows healing and repair cells to move to the site of the wound. During the inflammatory phase, damaged cells, pathogens, and bacteria are removed from the wound area. The combination of white blood cells, growth factors, nutrients, and enzymes create the swelling, heat, pain, and redness commonly seen during the stage of wound healing. So as we can see here, the image on the right is a scraped knee, and the inflammatory response, you can see that all the fluid is starting to build to try and do all those things that I had just mentioned. Third phase, the proliferation phase. In the proliferation phase, the wound contracts as new tissues are built. In addition, a new network of blood vessels must be constructed so that the granulation tissue can be healthy and receive sufficient oxygen and nutrients. Myofibroblasts cause the wound to contract by gripping the wound edges and pulling them together using a mechanism similar to that of smooth muscle cells. In healthy stages of wound healing, granulation is pink and red and uneven in texture, and healthy granulation does not bleed easily. Dark granulation tissue can have signs of infection, ischemia, or poor perfusion. Lastly, epithelial cells resurface the injury. The image here on the right is an example of healthy pink granulation tissue. The last phase, the remodeling phase. This is when collagen is remodeled from type 3 to type 1 and the wound fully closes. The cells that had been used to repair the wound, but which are no longer needed and are removed by apoptosis, are also known as programmed cell death. When collagen is laid down during the proliferation phase, it is disorganized and the wound is thick. During the remodeling phase, though, collagen is aligned along tension lines and water is reabsorbed so the collagen fibers can lie closer together and cross-link. Cross-linking of collagen reduces scar thickness and also makes the skin area of the wound stronger. As you can see, the image on the right, we have this wound that has been fully healed, and this is the beginning stages of the remodeling. Tissue remodeling can take anywhere up to 2 years for a scar to fully go away, and even then there still might be some semblance of scar tissue. So now that we know the 4 stages and understand the key factors, what are some factors that would affect wound healing? Well, here are 10 factors: nutrition, hypoxia, smoking, immunosuppression, chronic disease, age, genetics, surgical technique, wound management, and infection. All of these things, alone or in combination with others, can affect how quickly and efficiently a wound can heal. These last 2 of wound management and infection are going to be the focus of the clinical trials that I looked into. So, study number 1, comparison of a biological dressing composed of fetal fibroblasts and keratinocytes. The researchers named this dressing Sikafast on a split thickness skin graft donor site versus a traditional dressing, a randomized controlled trial. On the left, you can see the traditional wound dressing that we're all used to seeing, made of cotton and other synthetic fibers. And on the right, we have the bioengineered wound dressing. We would do with the collagen matrix, the fibroblasts. And so, as I mentioned, the biological dressing is composed of the active collagen matrix as well as fetal fibroblasts and keratinocytes. And so the researchers wanted to identify a set of patients who do not have other factors that can inhibit and detract from wound repair. The biological dressings, once identified, the biological dressings would be placed on similar wounds on the same patient. And so once these identified patients have gone through their surgeries and had the biological dressing and normal dressing applied, patients would go through extensive follow-ups with the clinician to track the rate of repair. Conclusions. So the results from these trials were inconclusive because they were unable to identify patients who fit the criteria. They did, however, manage to conclude that pain management was improved because exposure of sensory nerve endings was limited. During normal dressings, there is a adhesion that forms, and it does, when you're removing the dressing, it will cause new tearing to occur, and this can be very painful to the patient, as opposed with the bioengineered dressing. The bioengineered dressing became a part of the wound and would dissolve on its own. And so the researchers were unable to move their study from the animal testing phase to the human test phase because they ethically could not find patients who could fit all the factors and were also willing to undergo a elective surgery and have 2 types of dressing applied to see if one was more effective than the other. So this next study, we're going to look at managing infections. And so study number 2, the biomimetic networks with enhanced photodynamic antimicrobial activity from conjugated polythiopene and polyisocyanide hybrid hydrogels. So what these researchers did is that they created a hydrogel kind of like think of a topical ointment. And in this ointment, they were able to apply it to select areas to treat wounds and help uh, diminish bacterial infections. And so they did this with a combination of using red light. And now UV light, as we see on the purple spectrum over here to the left, is very commonly used, and it is a broad spectrum antibiotic treatment. However, this broad spectrum not only affects the genetic structures of bacteria, it also will affect the genetic structures of the patient. And so what they were looking at is these more on the 600 to 750 range of red light on the visible light spectrum, which is part of our everyday life, and it is not as harmful to humans. So how do they take this non-harmful red light and use it to help neutralize bacteria? Well, they took a photosynthesizer known as pigment, and they introduced it to the red light. The red light would then ionize oxygen particles, creating ROSs, and these ROSs would act on the bacteria and neutralize them. However, when it is just the pigment combined with the red light, there is a low level of ROSs that are produced, and it has a weak effect, a weak antibacterial activity. However, with this hydrogel, they took the pigment and they introduced PIC, which is a collagen structure. And when introduced to pigment, it creates a conformational change and focuses the particles so that when red light is introduced, there's an increase in ROSs that are generated. This increase in ROSs has a stronger antibacterial activity. And so they took this bioengineered pigment and PIC combination introduced with red light and tried it on 2 bacteria and 1 fungal sphere. These zone of inhibitions were dictated by the amount of gel that was applied. So an increased amount of the hydrogel resulted in more ROSs being created, and therefore creating a bigger and larger zone of inhibition. So why is this important? As a future healthcare provider, I'm hoping to be a nurse, and one of my top priorities is going to be patient care. Part of the patient care is going to be ensuring that they are spending the least amount of time in the hospital. According to the CDC, biofilm formation prevents wounds from healing and can lead to other life-threatening infections and inflammatory responses. Being able to effectively treat and manage wounds will lead to better patient outcomes and decrease the likelihood of an infectious disease unknowingly spreading to other patients in the hospital. My role as a healthcare professional will not be limited to the hospital. I will likely be a resource of information for my family and close friends. It is important for me to maintain a critical eye when reviewing new information, studies, or treatments that are being published. If I am unable to maintain my critical thinking skills, I will not be able to assist in dismissing harmful misinformation or providing clarity to helpful and potentially life-saving advice. And here are my references. Thank you.